Chair, the live webcast has started now. Thank you.
Thank you very much. Welcome to the board and our colleagues and partners to the Adult Health and Active Lifestyles Scrutiny Board meeting. I'd like to welcome you all here this afternoon. And before we start going through the agenda, could I welcome and ask everybody, members of the board, to introduce themselves. I'll start in alphabetical order, so I'll start with Councillor Anderson.
Sorry, Chair. Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adeline Wharfdale Ward.
Thank you. Dr. John Beale.
John Beale, co-opted member of this board. I chair Healthwatch Leeds.
Thank you very much. Councillor Elliott.
Councillor Judith Elliott, Morley South.
Thank you. Councillor Harrington.
Hi, Councillor Norma Harrington, Wetherby Ward.
Thank you very much. Councillor Iqbal. Can you hear us, Councillor Iqbal? Right, we'll come back to Councillor Iqbal. Councillor Knight.
Hello, it's Councillor Christine Knight, Weetwood Ward.
Thank you very much. Councillor Latty.
Good afternoon, Councillor Graham Latty from Guiseley and Rawdon.
Thank you very much. Councillor Lay.
Hello, Councillor Sandy Lay, Otley and Eden Ward.
Thank you. Councillor Reagan.
Hello, good afternoon. Councillor Denise Reagan from Burnham Toss and Richmond Hill Ward.
Thank you. Councillor Trustwell.
Councillor Paul Trustwell, Middleton and Belle Isle.
And Councillor Wenham.
Good afternoon, Councillor Wenham for the Wrong Here Ward.
Thank you very much. Are you able to introduce yourself, Councillor Iqbal?
He is on mute.
Right, yes, he is. So maybe he's just not able to come in at the moment. So we'll see if everything's all right with Councillor Iqbal. Okay, so thank you very much and for introducing yourselves. Can I invite Harriet Spate as Governance Officer to run through the first 5 items of the agenda, please?
Thank you, Chair. Yes, of course. So first of all, under agenda item number 2, there are no exclusions to the public or press today. Under item 3, there are no late items. Under item 4, can I ask that board members declare any disclosable pecuniary interest, please? And I'll take that as none. Thank you. Oh, sorry, John. Yes.
I am a member of the NHS England, Yorkshire and the Humber Dental Commissioning Executive. No financial implications, but I just need to declare that.
Thank you.
Thank you. And then moving on to agenda item number 5, Chair, there are no apologies, but we have received notification today that Councillor Smart will be arriving slightly late this afternoon. Thank you.
Thank you very much, Harriet. Really appreciate that. So can I go on to item 6 of the minutes of the 14th of July 2020? And can I take them as a true record? I'll take silence.
Yes, move on, Chair.
Thank you. Thank you, Councillor Reagan. Anybody to second?
I'll second, Chair.
Thank you. Thank you, Councillor Trustwell. And any minutes arising, if anyone wants to, anything arising from the minutes, sorry. Thank you very much. So we'll move on to item number 7, which is the impact of COVID-19 on accessing NHS dental services in Leeds. Angela, can I ask you to introduce yourself, but also introduce this item, please?
Thank you, Chair. Yes, I'm Angela Brogden, the Principal Scrutiny Advisor to the Board. So in relation to this item, Chair, previously the Board has looked at how the Council and its partners are working collaboratively to support a broad range of patients, service users and stakeholders across the health and care system during the COVID-19 pandemic. However, following a request that was made by the Board, this agenda item is focusing specifically on the impact that COVID-19 has had with regard to accessing local NHS dental services, and also exploring what support is being provided to resume NHS dental services safely and effectively and in accordance with the advice that's set out by the Chief Dental Officer. So I'll pass back to you now, Chair, to introduce those that are attending for this item. Thank you.
Thank you. I was a bit kamikaze with my mute button there. So I'd like to welcome Councillor Rebecca Charlwood, Executive Member for Health and Wellbeing and Adults, Emma Wilson, who's Head of Co-Commissioning, Yorkshire and Humber, NHS England, Jane Moore, who Dental Network Chair. Have we got Jane in the call as yet?
I think she's struggling to join, Chair.
All right, if an officer could maybe help out with that, that'd be great. And Sam Prince, who is Executive Director of Operations, Leeds Community Healthcare NHS Trust. So I don't know who wants to go first. Emma, do you want to speak to this item?
Yes,
but actually before that, Councillor Charwood, would you like to introduce yourself and say hello? Don't know whether she's able to. We'll get started with Emma, and hopefully Councillor Charwood will be able to join the call in a bit. But thank you, Emma. Sorry about that.
All right, don't worry.
Yep.
Good afternoon. As we've explained, I'm Emma Wilson. I'm Head of Co-Commissioning for Yorkshire and the Humber, and I have commissioning of dental services as part of my role. I am going to assume that the paper that was circulated has been read by colleagues, and that probably will generate some questions, but I thought it'd be helpful just to give a little bit of context to some of that. Colleagues may be aware that at the end of March, the Chief Dental Officer advised all dentists to cease providing services, and that was based on the risk assessments that were done in terms of services that could be provided without the relevant PPE. And as you would appreciate, and hopefully when my clinical colleagues get on the call, they'll be able to give you a little more detail around the clinical impact. But essentially it means that a number of procedures that are undertaken by dentists do generate the infection rates that are requiring of high level PPE. So that's level 3 full PPE. So the services were all ceased. All our practices were advised that they should not provide services. And we had to provide additional emergency services in Leeds at Leeds Teaching Hospitals Trust for patients who had symptoms of COVID and did require dental care. With effect from the 8th of June, the dental officer revised that guidance and asked practices to start to think about resumption of their services. Now, that was very much predicated on the fact that they had the relevant PPE, were able to use it effectively, and could deliver urgent care to those patients who had been triaged and who required it. That now in Leeds, you can see from the picture there, is a strong position. So we now have 86 practices and all but one are providing urgent services and can provide urgent services using the relevant PPE. They all have somebody who is trained, who can train others and can use that relevant PPE to provide those services. The large number of them have also gone on to be able to complete courses of treatment for patients. So this is patients who call the practice, irrespective of whether or not you are a regular attender at that practice. Those practices will triage you and will then offer you, where clinically necessary, an urgent appointment. You can see from that although there was no timescale put on that by the Chief Dental Officer, in actual fact, it's a really strong picture for Leeds. Our practices are offering triage to patients who call and can respond with an urgent appointment as and when the patient needs it. They're also in the large part starting to do those completions of courses of treatment. So that was generally patients who had started treatment before we went into the COVID pandemic, or those that have identified it as needing a course once they've had that urgent care responded to. The challenge for us is how we resume to full services for dental NHS dentistry. And whilst it's great that we are able to meet the expectation of the Chief Dental Officer, there are still some real challenges with patients being able to see a dentist or a hygienist for their regular care. And I think it's really important to say this isn't just about dentists, it is about the wider dental workforce, and then being able to provide that service. So whilst we have been able to ensure that all patients have access, starting with triage, in terms of prevention, wider dental issues, and resumption of some of those issues, we're still facing some challenges. The challenges of the PPE and the guidance that's surrounding resumption of services is it's very restrictive, and it means that many of our practices are only offering approximately 50 to 60% of the capacity that they were offering prior to the COVID pandemic. And this is in large part because of the work that's required after each patient has been seen. There's a certain expectation of time. I think it's about an hour, known as fallow time, that the dentists have to wait before they can then start the cleaning and bring other patients in. And of course, there's also the issue of all staff being appropriately supported with the relevant PPE. So by definition, it means that the capacity that our practices are able to offer is pretty limited. And we've been given a clear steer over the last week that guidance is unlikely to change in the short term. I'm sure I don't have to tell you that we're still facing some of the challenges of the COVID pandemic, and in dentistry that's no different. So it's felt that in the present time we need to retain that guidance, work with our practices to help them prioritise patients as effectively as possible, but make sure that they are resilient. So if we do move into a more severe spike of COVID, which I think is expected, then those practices could still continue to offer a service to patients. So we have a level of resilience. So the sort of headlines for that are, all our practices are open. They are not being selective about the patients that they will triage. If patients call, they will triage them, and they will then offer them an urgent appointment if it is clinically necessary. There are some challenges in terms of being able to implement and deliver a service with that level of PPE and the guidance that is required. And we are working with them to help them manage the backlog of patients. And there is a backlog of patients. There are a number of patients that sit on practice books or waiting lists that do wish to be seen for their more regular care. And they're starting now to work through some of those. I'm mindful that there might be questions, Chair, so I don't want to give too much information in case colleagues would like to ask some questions.
I'm seeing that Jane might be joining us. Can you hear us, Jane? I've just seen her pop up. So.
I think where Jane comes is because she's the local dental network chair. Jane would be able to explain the challenges of PPE and the ability of practices to prioritise their patients more effectively than I can. But I'm very happy to take questions if colleagues have them, and we can try and field them as best we can.
Perfect, and we have Sam Prince as well. So in terms of questions, I'm going to start with Councillor Reagan, then Councillor Trustwell, Councillor Lay, Councillor Knight, and Dr. Beale. Okay, and I will obviously come to as more people put their hands up. So can I start with Councillor Reagan, please?
Thank you, Chair. Yeah, Emma, you say that all the practices are now open and they're taking in patients and doing the treatments with the right PPE. I have to question that in some sense, that the hygienist type of work that the dentistry does, it's a deep clean, which with the spray things and to stop the bleeding in people's gums and things, that's not taking place. And I've got a fear for constituents that don't have that treatment, that's going to be a long-term dental decay, which is going to have more effects later on in so can you explain how what type of PPE is used to make sure that that practice can happen. And if we haven't got that, why haven't we got it?
Emma, would you like me to
Oh,
answer?
sorry, yes, if you're on the call, that'd be really helpful. Thanks, Jane.
I'm sorry,
Welcome,
I was late.
Jane.
I was given the wrong ID and to join the calls, but it's sorted now. First of all, to do not all that sort of deep cleaning, but some of it, you need, it's an aerosol generating procedure. So the number of aerosol generating procedures that practices can carry out is very limited because there's an hour of fallow time in between the treatment and the surgery being able to be used again. So limited deep cleaning can be done without the aerosol generating procedure, but it is still effective, but it's very time consuming. And at the moment, practices are not able to offer all routine treatment because they're having to prioritise people with an urgent need and vulnerable people, because the number of patients they can see is so very severely restricted. So when patients urgently need anything doing, and they are getting that done, but the more routine stuff is having to be put on the back burner a bit just because there isn't the capacity to get through all those patients.
Thank you. Is that okay, Councillor Reagan, or would you like to come back?
It isn't okay, but I don't want to come back now.
No, okay. Councillor Trustwell.
Yes, thank you, Chair. I have similar concerns to Denise, but they've been covered. I just wanted to put this in the broader context of access to dentistry in general, because the emphasis is we are talking about NHS dentistry. And we know that over the last couple of decades, there's been a massive exodus of dentists from the NHS. Some left the NHS completely, some do some NHS work, some will provide NHS care to children, providing the parents have got a contract with a private insurer. So when we talk about the 86 practices, are we talking about all the practices in Leeds? If not, how many practices are there, and how many practices are not necessarily following this NHS approach, or are they expected to? I'm just trying to get a feel for what the impact basically of the overall privatisation of dentistry over the last 20 years has created, so that we know exactly what we're talking about. Although it is very refreshing to hear that if I go to an NHS dentist off the street, so to speak, that they will actually triage me. So that's a vital component, I think, in this period.
It is, yes. So the 86 practices are NHS practices. I don't have any guidance or authority with private practice. We have the 86, and with the exception of one, and I think I've articulated it's due to sickness and there is a buddying arrangement, all our practices are offering triage, and then where it is clinically appropriate will offer treatment in the way that I described at the beginning. I think you're quite right, though. This is definitely in a context of a challenged position. We've always been challenged with our access to dentistry. So we didn't start in a great place, if I'm really honest, and I think we've been quite upfront about that in terms of our previous conversations. And one of the frustrations for us is, as commissioners in NHS England, is that we had a plan to try and invest a little more and put it into areas of greatest need and greatest concern. That plan is still something we have got in the back of our minds, and we've still got that there. But I think there's two challenges for us. The first is getting through this COVID pandemic and making sure that we can offer a resilient urgent service with a view to moving into a resumption. And the second is that we have to be really, really clear that actually financially things may be slightly different for us in the second half of the year. But the commitment that we want to do to try and improve access generally is still there. And I'm sure that'll be something that we can have a conversation about as we are a little clearer about the funding. But unfortunately, I can't speak about the private dentists, although they have been involved in the urgent response. So when their patients have needed an urgent response, they've been working with us over the last 6 months. But I don't have any commissioning responsibility for them.
Would you like to come back?
Okay, yeah, just very briefly, thanks very much for that answer, Emma. I think it would be useful, obviously not now, but to try and find out what the provision of dentistry is across the city. I'm sure we've had figures in the past within the NHS and outside of the NHS, and to support our colleagues in the NHS to try and extend that accessibility and provision, especially in wards like mine, where I think dental disease is at one of the highest rates. But that's for another day. But thanks very much for that, Emma.
And it is something we want to focus on very much.
Thank you. Councillor Lay.
Thank you, Chair. I've a couple of three questions really to Emma and perhaps Sam or even Jane. Just to clarify around the AGPs, the aerosol generating procedures, and enhanced PPE. So that requires level 3 FFP. How with a building up store so that we don't run out of PPE over the winter period? Are there any problems with accessing enhanced PPE for dentistry? Secondly, I just wondered why, if an AGP is undertaken, and I assume every procedure by definition in a dentist's going into having a look in one's mouth is an aerosol generated procedure. So if every procedure is an aerosol generated procedure, you say there's an hour's gap. I assume that's to allow the droplets to fall out of the air. I just wondered why that's twice the length of what we're using as our 30-minute barometer in intensive cares and A&Es, etc. So I just wondered why it's an hour and not 30 minutes for when we do AGPs. And finally, perhaps this one is for Sam, page 11 of the report, point 2.1, the last bullet point talks about subject to the availability of enhanced PPE. That's fine. Urgent dental care centres are being established in a minimum of 10 locations across the city or across Leeds. Being established, whereabouts are they going to be? There's no detail in the briefing as to what do we do if we have an urgent need for dental care outside of the traditional dental hours. It alludes to it there, but if we could just have a little bit more detail. Thank you.
Shall I take them in reverse order, just because my memory, they might need a bit of prompting, but if I start with the reverse order, so I think we might be looking at two slightly different things. We did establish 10 urgent treatment centres across Leeds in the pandemic. So when we started at the end of April, when the Chief Dental Officer asked us to establish urgent dental, we had 10 centres in Leeds. Those 10 have now grown into the 86. So now the procedures that you would get within the urgent treatment centres, you would get, if clinically appropriate and necessary, in one of the 86 practices. So
during office hours. During office hours.
Yeah, in normal working hours, yes, and then you.
Yes, I'm really asking about out of hours,
oh, sorry,
which make up most of the time that you know, that's all weekend and every hour after 5 p.m. until 8 a.m. If I have if I have a dental, well, that's what I assumed that meant by urgent dental care centres.
Well, that is a good point, actually. Yes, you're right. Prior to COVID, we had urgent treatment and then we had regular NHS access, didn't we? What happened was we had to deem it all as urgent. But the process is exactly the same. The triage, and then where clinically appropriate, you would be seen. But the provider has to have level 3 PPE. Now, Jane maybe will be able to help us understand why we don't have an hour's fallow time. I think that has been something that has been discussed quite a lot. But if I could just address the issue of access to PPE, which you raised with us, I think it was well documented how challenging it was to have access to PPE at the beginning of this pandemic. And we did struggle an awful lot to have access to that. We also struggled in the training because in order, as I'm sure you'll be aware, in order to be able to use level 3 PPE, there does need to be a tester and somebody who can make sure that their colleagues are safe as well. We have now made sure that in all of our practices, we have that system in place. We have that provision in place. And we also have made sure that all our dentists have access to the central ordering systems. So it means that they can order as according to their need, and they are now trained and appropriately trained to be able to use that, that PPE. I think it's a really good question about the resilience as we go into winter, and we have got a meeting later today where we are talking about how we get some of that assurance as we go in. But that's essentially where we are. We're in a far better place, and we're certainly more resilient in terms of the number of dentists who can use it appropriately and train others to use it as well. Jane, I wonder if you would be able to answer the question about the fallow time. Is
yes.
That's the guidance, isn't it, that we've received?
Absolutely, yes. There can be a reduction in the fallow time to 20 minutes, so long as the surgery has an air exchange of 10 to 12 per hour. And unfortunately, although quite a lot of our surgeries are trying to have this equipment installed to reduce the fallow time, not all can at the moment. But in the hospital situation, that'll be why they can reduce the fallow time. So that accounts for the difference.
That's a reasonable answer. Thank you. Yeah, there's a technical reason for that then.
Yeah. And in terms of out of hours, we obviously still have all our urgent treatment centres where patients are booked in via 111 and they are operating at full capacity, you know, as they were in the pre-COVID situation. So out of hours is catered for in a separate way.
Okay. So those 10 locations were pre the 86 dentists.
As well as, sorry, yes, sorry, I've confused things. I think it's the use of the urgent treatment centre, isn't it, that's confusing. We still have the way that Jane's just described, we still have treatment centres that are for out of hours in the way that you describe, but we also had 10 urgent treatment centres in primary care for in hours, but they have now grown to be the 86. Yeah, does that make, sorry if I've confused.
Yeah, that does. Yeah, that's fine. So I could still, if I or residents could still access a dentist in an emergency at 9 o'clock on a Sunday night.
Absolutely, absolutely. All our processes are still in place and are more resilient now because of that PPE and the confidence around the procedures that they can do.
Thank you all.
Thank you. Can I bring in Councillor Knight, please?
Okay, thank you. My concern is around the availability of NHS appointments, which was difficult pre-COVID, and there's likely to be an increasing demand for those, especially when furlough finishes. Have been increasing numbers of people in financial dire straits who will be unable to afford private treatment, some who may not even be able to afford NHS prices, although another question linked to that is, do they get that free if they're on universal credit? But even if that is the case, what can we do locally to increase the numbers of appointments and availability for people who are in need of treatment but cannot afford private appointments or cannot afford even NHS costs? Is that something that's being looked at? Thank you.
I think you're absolutely right, and that goes back to the question that Councillor Truswell asked me about our plans to invest more and to work with our workforce, because an awful lot of the services that we want to be able to provide are not just delivered by a dentist, they're delivered by the wider dental workforce. So I think there is that's something that we were very focused on and continue to be focused on. I think the challenge we've got at the moment is to build back up that access to make sure that actually it is access that does at best can recognise the challenges of those who would struggle to access a dentist. The first thing we've done is made sure that every dentist would at least be able to triage somebody, because you'll know before, patient practices who had not seen a patient regularly, although there's no list, patients struggle to access a dentist because if they hadn't been seen recently or regularly, then a practice would not see them. One of the arguably positive things that's come out of this is that now our expectation is that practices would always triage and acknowledge a patient when they call and would respond to their urgent need. Now that doesn't, I appreciate that doesn't cover your point about prevention work and longer term support for patients who need it. So that's the bit that we were talking about earlier that we've got to focus on once practices have been able to consider different ways of delivering in this environment. And it's a bit of a mixed bag. We have got some practices that are starting to do that, that are starting to see more appointments become available so that they can extend their access. Patients who were eligible for relief on payments before still are. So your point about whether or not they pay, that doesn't make it, that hasn't made a difference at all. That still applies. And one of the challenges that we've got is because less patients have been seen, there are less patient charges coming through our system. So that then will have an impact on what we can do, because we had an agreement prior that we would reinvest that to start to target areas of greatest need. And that was my point earlier about how we'd got that commitment, the investment money that we'd got, we could start to think about care homes, nursing homes, other provision that we would need. No fixed abode. We want to do some work with those communities. And it's still our hope and intention that we can do that. But the challenge at the moment of the capacity in dentistry and that reduction in funding will make it a challenge, but it's still something very much that we want to focus on. It hasn't gone away. And colleagues like John do keep us on the straight and narrow in terms of the clinical exec, and it's right that we do that because it's something that we are focused on. I don't know if that, I hope that answers your question.
Yeah, to some extent, thank you. Yeah, I think it's just making sure that we've always got that there as in the forefront, really, when making plans going forward, and a recognition that there's obviously going to be an increasing demand for that. And I'm just concerned that there is equality, if you like, across the board in dentistry, and which there hasn't been anyway since the introduction of more private appointments. But you know, we don't want that worsened because of COVID. And it's again going to be the people who are most affected by COVID financially who are going to suffer in terms of dentistry as well. And it's about minimising that gap between the rich and the poor, I suppose. The haves and the have-nots as much as we possibly can going forward.
I completely agree. And if it's of any comfort at all, the group that I'm joining at 4 o'clock is made from it's the component from dentistry, and they are desperate to start being able to see, increase their capacity. They know who those patients are, so they have a group of patients, and they are aware that there's an unmet need out there as well. So they're pushing us to think about the guidance and whether or not the guidance is relevant, how we can do, immediately start to do something. So this is not dentists sitting on their laurels and only that they're working hard to try and increase their capacity. So,
and I think that's a very positive move forward, that the fact that you mentioned that they're no longer saying, well, if you haven't seen us for a while, you can't have an appointment, because that has definitely been the case. Whereas, even people who have not been to the dentist for some time can still see that dentist if there is an appointment. So that is a positive move forward.
And that was something that we put in place in Yorkshire and the Humber before the national direction, and we're still waiting for national guidance, and we have pushed for that to remain in that operating procedure, because that has really proven some dividends for us. It's not the full answer, but it's a good way to making sure that patients can at least initially access and speak to a clinician.
Absolutely, it's a step forward. Yeah, thank you, Emma.
Well, as Emma mentioned him, and he's next on the list, Dr. Beale.
Thank you, Chair. Thanks very much, Emma, for that introduction. 3 questions, but I think fairly quick. Thanks for reaffirming that dental practices are now able to get adequate enhanced PPE. I know that was a problem when they first started opening up, and it's good to know that they are now able to get it. There have been a number of anecdotal comments that dentists are charging for PPE. Now, if they're private practices, that is fine. Private practices can charge whatever they like for whatever they do. But of course, they're not allowed to within the NHS. Can you confirm that as far as you are aware, there has been no attempt by NHS practices to make a charge for PPE? The second is about plans for the future. And actually, your way of describing the 86 practices being an expanded number from the 10 urgent treatment centres which were set up is actually, I think, quite a helpful way of looking at it. So can we assume that if there is another spike, and I think most people who are experts in the field say that there will be spikes, that actually those, let's call them, the 86 urgent treatment centres will continue to provide that, except of course for those who have to close because of staff isolation or other health reasons. And thirdly, it's not specifically related to COVID, but I think it's been highlighted in some cases by COVID, and is of particular interest to the Scrutiny Board in terms of looking at equity and diversity. And that is the Accessible Information Standard. As you are aware, it applies to all health professions. I know the CCG are looking at it in relation to general practices and the wider medical profession. I just wondered what Healthwatch England can do to ensure that dentists, dental practices are implementing the Accessible Information Standard, and making sure that people with learning disabilities, people with hearing problems, people with visual problems, in days when at least the triage is likely to be on the telephone or online, but more generally, is NHS England doing anything to ensure that dental practices are conforming to the AIS?
Thanks, John. Again, I'll take them. My memory allows me to take them backwards, so if that's okay. It's a really good point about the accessibility standard, and it's something that we've actually got on our agenda for our next contract meeting. Because what I'm looking for is what levers we have to make sure that our practices are actually conforming to that. Sam may well be better briefed on it from her services perspective, but I think whatever levers we have will be part of the national contract. And actually, the other thing for us is how we use the national contract to do something we see as a quality indicator as well. It's not just about the standard contract. It's very easy to say it's in the contract, but actually what difference is it making and adding to the value of the information that we've got and how we use it. So thank you for the prompt. I think that's as full an answer as I can give you at the moment, but I'd certainly be happy to get a fuller answer when we know about our processes and also where we will take that information when we know we have it, because I think that's the important bit, not just making sure that it's there. You asked about PPE and charges. We are aware that charges have been made to patients in terms of PPE, but as far as we are aware, that is not the case with NHS providers. Our local dental committee chairs are very, very clear that where they know that's happening, they will call it out. And we haven't had any experience of that. But I am aware that private practices have been making charges. What we have done is ask them where we can to make sure those charges are clear to the patient before they start their treatment. But as we've explained, we don't have any commissioning responsibility. So I just think that's a good standard practice anyway. And then in terms of the third question, John, I'm really sorry if you could just prompt me with what your third question was about the urgent treatment centres.
Yeah, are we in effect in a situation where we will have around about 86 urgent treatment centres up and working, ready to go if we have a local lockdown?
They are working now and will respond if we went into a local lockdown. That's the one thing though that we haven't mentioned is that we have still kept the centre in Leeds for patients who are showing symptoms of COVID. We actually didn't have any patients access that, but we have kept that. So with that service is there for patients who have tooth challenges when they have COVID as well, which would make it very difficult for them. But in terms of those practices that are offering services at level 3, then that would continue.
Thank you, Chair, and thank you, Emma, for giving very reassuring answers.
Yes, thank you very much. And finally, I'm going to bring in Councillor Elliott. Thank you, Councillor Elliott.
Right, can you hear me?
I can.
Can you hear me?
Yes.
Right,
yes,
thank you. I'm going back to Denise's comment about deep cleansing. And what I know we're dealing with COVID at the moment. However, it strikes me that our children, and it's got to start with our children, need to be cleaning their teeth properly and thoroughly, morning and night, to make sure that their teeth can be kept as free from problems as possible. Now, does this happen, please? And if not, can schools be given information to be given to the children? Because to save such pains and aches, and toothache is absolutely dreadful, as we all know, we've all experienced it. The cleaning of the teeth is really something that needs to be dealt with. Otherwise, that plaque buildup causes such problems with both the gums and the teeth. Thank you.
Thank you.
Can somebody
Jane,
answer?
I wonder whether you would be
Right.
able to answer that for us. I can see you're online now.
I've also got Sam who's saying.
Oh, smashing, brilliant.
Yeah,
Thanks,
yeah.
Sam.
Do you want to come in, Sam?
Yeah, I was just going to say that the 0 to 19 service, which is the service that was previously known as health visiting and school nursing, has oral health promotion as part of its contract requirements. So we work with parents and children when they're very, very tiny, right through school. So the oral health promotion team going to schools as well to remind around the importance of teeth brushing and so on.
Well, could I just come back and say perhaps we perhaps ought to try and push it more, perhaps with this COVID here, and when people haven't been able to get to a dentist, it just shows how important it is to try and keep our teeth in the best possible state that they can be kept in. Yeah. Thank you. Thank you.
Thank you very much. Yes, and it's that long-term preventative work that I know there's a lot of work going on in the community. And pre-COVID, there was a lot of work going involving dentists doing prevention work, wasn't there, Emma? And making plans for that. And Emma and Jane were explaining. In fact, it was one of the last meetings I had was with you two.
Just before lockdown, wasn't it?
Literally. Yeah, it was literally at the last time I think I was in the Civic Hall.
Was.
Yeah.
Yes.
And and there were great plans, which obviously, like most of our lives now, have been put on hold. But I know that there were plans, and they will hopefully come back for hygienists and dentists to go into schools and actually deliver that preventative work themselves.
So I think so, Councillor, and I think the other thing just to mention is, whilst I've talked about money and that money will be required, we have got a commitment from our dentists to work differently as well. And some of the challenges are very much about PPE at the moment, but once that has dissipated a little bit and guidance is reviewed, or hopefully we find a vaccine solution over the next months, then our dentists are committed to looking at their workforce differently. They are committed to working differently with other parts of the sector. So even if the worst case scenario is that we don't have some of that additional funding that we know will spur some of that on, we absolutely we will be doing something. And I think the last 6 months has probably prompted our dentists, because they've worked together far better than they had done prior to COVID. We've got practices that hadn't worked together that have buddied up. We can start to use different ways of ensuring that.
Thank you.
Thank you very much. A really important point. Can I say a huge thank you from the board and myself to Emma and Jane and Sam for joining us on this item. It's really, as you know, it's really important. Your dental health is really important. And as Councillor Elliott said, when you've got toothache, it's just, and we've discussed this before, just the worst. It dominates your entire life if your dental health. So many thanks for joining us, and we'll look forward to welcoming you back in the future about any more updates, and hopefully if we get this pandemic under control, like you say, but moving forward in that partnership working that dentists have done now as in the pandemic, there has to be some positives that come out of that, and it'd be exciting to hear about that in the future. Thank you very much.
Thank you.
Thank you. Can I invite Angela to introduce item 8, which is the Leeds Health and Care Winter Planning for 2020-21 and business continuity planning in adults and health. Thank you.
Thank you, Chair. This Scrutiny Board had previously maintained an interest in the Leeds Health and Care Winter Planning process, and this year in particular, with the additional pressure within the system due to COVID-19, the Board was keen to consider what early progress has been made towards ensuring that the Leeds Health and Care system is extremely equipped and prepared to respond quickly and appropriately to any change in demand or circumstances that winter and the pandemic may bring. So as part of this agenda item as well, information is also being provided on the range of business continuity plans that's held within the Adults and Health Directorate and how these were also used in the COVID-19 crisis, particularly as such plans across the Council are also recognised as an essential part of the resilience and stability of the service. So again, Chair, I'll pass back to you to introduce those that are joining for this item. Thank you.
Thank you very much, Angela. So we have Councillor Rebecca Charlwood, Executive Member for Health, Wellbeing and Adults, Victoria Eaton, who is Director of Public Health, Shona McFarlane, Deputy Director of Social Work and Social Care in Adults and Health. And also I'd like to welcome Kath Roth, Director of Adults and Health. And thank you very much for being able to join us today at the meeting. Sam Prince, who we've just heard from in the previous items, thank you very much. Executive Director of Operations at Leeds Community Healthcare NHS Trust. Helen Lewis, Interim Director of Commissioning, Acute Mental Health and Learning Disability Services for NHS Leeds CCG, who has led on producing the report. So thank you. Thank you, Helen, for being here. Saj Azeb, who is Deputy Chief Operating Officer for Leeds Teaching Hospitals NHS Trust. Look forward to hearing from him later. Gaynor Connor from the GP Confederation. Joanna Foster-Adams, I don't think will be able to join us. And we haven't yet got Alison Kenyon, I don't think, on the meeting. So hopefully she might be able to join us later from the Leeds and York Partnership Foundation Trust. So can I ask Councillor Charlwood to introduce the item? Thank you very much. And then and maybe if you could direct who's going to speak on it. I'm assuming that Helen Lewis will want to speak on it, and then we can take different questions. Thank you.
Yeah, thanks. I'll just briefly introduce this just as in terms of underlying the importance of, and good afternoon everyone, by the way. It's lovely to see you all. Yeah, just underline the importance of this sort of planning. This is how we really come together as an integrated system, and the test of our integration is borne out by our winter planning and our, you know, the papers that are before you today. You know, we do a huge amount of work every year to get this plan really tight and ready for the challenges ahead. And normally we have tough challenges in winter, especially with, you know, year upon year reductions in resources in the public sector for the last number of years, but especially obviously this year. And we do get, you know, flus and, you know, greater demand on services in winter. And a huge amount of work goes into avoiding hospital admission, especially in our older population, and we do a huge amount of work around falls prevention and everything else. So there's just a massive amount of work that goes into allowing the system to cope through winter. But this year is absolutely different. Obviously, we've had a whole year of unprecedented demand on the system with the pandemic, and then we'll have that. Plus, we'll have our normal every year annual issues that we have to face. So huge amount of work's gone into it, and thank you to all the officers and across the health and wellbeing sector in the city. Huge amount of work has gone on, and thank you for your continued support and commitment to our integrated journey together for the population of the city. So I'll hand over to Helen, I imagine, who wants to speak first, but whoever else, yeah.
Thank you. Thank you, Councillor Charver. Thank you, Councillor Hayden. I think it's probably fairer to describe this as ongoing resilience planning than it is to describe it as winter planning. I think that the system hasn't stopped at all since March. And I think one of the things that we've reflected on throughout our planning is this is a continuous cycle of planning. And the reason this year is different, I think we've rehearsed in some of the papers, is just probably worth just sharing with councillors why this year is different. So I think the thing that's really different this year is we come into it with a backlog of people that we haven't been able to treat. So I think in previous years, we've been able to step back some of our elective activity relatively safely for 4 or 6 weeks and use that space to treat our acute patients. Our commitment as a system, as far as we can, is to not do that because we've built up such a backlog. So our ambition, whether we can achieve it or not, I don't know, is to maintain our elective capacity as far as we can. So that's added a barrier. The second barrier is that there are social distancing requirements in all our settings. So we've had to take beds out of our wards, we've had to take space out of our waiting rooms. We were just talking this morning about discharge lounges. To keep people socially distanced, you need a bigger space. Protective equipment, I think, is a good news story, hopefully better than it was 6 months ago. So I think we're more resilient on our PPE. So that is a really good news story about going into winter. Clearly, our staff will be affected by whatever else happens. So resilience planning around staffing, our ability to use working from home is much greater than it was, because at least in the meantime, hi Alison, nice to thank you so much for joining us. So we've got people better set up to work from home. So I think we're better able to use the skills of our remote working staff. But again, if people go into shielding or people have to self-isolate, we're going to see increasing pressures on our staff again. I guess testing, I'm sure that Victoria will answer questions and I'm certainly not going to speak to it, but I think there will be an ongoing set of issues around testing. And even if testing flows well, it adds a delay into bits of our system just inevitably until we get a 15-minute test. Then everything just takes a bit longer. And what that does is that then creates the need to stream our patients. And every time we stream our patients into different settings, we create a delay and we create less flexibility. So if you have to have your waiting for results patients separate from your COVID patients, separate from your non-COVID patients, then it's not the same as how we've had it in the past. So there's a whole set of constraints. I think the other important area, though, is around flu and our flu planning and our ability to really plan proactively with our patients. And I think we're probably further ahead around really considering the needs of patients at risk than perhaps we would have been in a previous winter, because we're asking, and I'm sure Gain will be happy to answer questions about it, planning in primary care all the time now about what we can do to proactively reach out to those patients, to optimise them, to do some of that prevention that we've talked about in the past, but possibly had less focus on than perhaps we will have this year. So that's a little bit of the context. I think we've rehearsed in the papers some of our aims, but I guess for me, our main ambition is to continue to work as partners as we have done throughout the pandemic. And there's lots of really good examples around all the time now. We're meeting weekly as a set of chief operating officers, just always thinking about how we can use staff more flexibly, how we can use our resources more flexibly, how we can use our buildings more flexibly, just to manage that capacity. And there's all sorts of evidence of that. We will continue to do that, even though the whole number of staff that we have between us is likely to shrink and flex. I think the other thing that's different this year is that we're working much better on neighbourhood footprints. So we've got some really good integrated working, for example, between general practice and the neighbourhood teams around really understanding the resources available in a locality to see if people can help one another. Whereas historically, I think those relationships have not been as strong as they are now, strengthening all the time. And again, I'm sure Sam or again, I'd be happy to answer questions on that. I think we've got more of a population focus. I think, you know, we're thinking, so this week we're looking at some alternative clinics for children, just to kind of think about the needs of individual patients and then how skills across the city can work together to deliver some of that care. I think the other things that are embedded better than ever before probably are communications. So we've had a conversation this morning and we've already got conversations and comms back out this afternoon. As we're seeing people presenting in places where we think possibly not the best place for them, our comms teams are much better embedded. Both the comms teams from the council, but comms teams in the CCG are part of our planning group and part of our daily planning. So I think our engagement with the public and our consideration about how we talk to the public is much more embedded in the world. Our engagement with third sector groups, our third sector partners are part of our weekly resilience conversations. and are working very closely with us and seeing that full offer of third sector partners as partners in health and care, which I know that we've talked a lot about, but it feels, I think, even more real, and colleagues will be happy to comment on that. And so I suppose that what we've done is thought about all the things that we can do, and then keep thinking about all the things that we can do. And I suppose the assurance that the only assurance I can give you is that people are fully focused on doing their very best for the citizens of Leeds and the wider system. The stress testing is difficult because I would say today we're already stress testing as we see COVID numbers rising in the city, as we see demand rising, as we try and keep patients, as many patients possible, as treated. This is a live stress test, and we will do all that we can as flexibly as we can with partners to maintain that. We're a bit out of magic wands, so this is just hard work, grit, flexibility, commitment, use of independent sector partners. Independent sector partners, probably just worth saying, Saj might want to add, both Nuffield and Spire are working absolutely tightly in partnership with us. We're using their capacity. They are working as system partners to maximise the care of our most needy patients. We are independent sector providers in the community the same. We are treating people in order, and they are really all working in partnership. So I think the partnerships are as strong as I've seen in 20 years in the city. The demands are probably significantly higher than I think any of us have seen in our times in health and care. So people are seeing the papers. I think probably easiest, Councillor Hayden, if we just ask councillors if they've got specific questions to any partners, if that works for you, because I think that's probably the easiest way to address any queries. Is that all right? So you'll know who to shoot them to, but I'm happy to redirect if you think if it's not obvious.
Thank you very much. No, thank you for that, Helen. And I think you're right. If we just get down to, and thank you for the papers, and we will change the name of it, because to be honest, it hasn't been a winter plan for quite some time, has it? and especially not this year. It kind of, you know, summers have not been particularly easy for people for the NHS for a number of years now. So we'll change that word into resilience planning. But if I can ask councillors to raise their hands, and as Councillor Latty did initially. So we'll start with Councillor Latty, please.
Thank you very much, Helen. Yes, the question here, planning for winter or planning for the future, I suppose, but the winter is the hard bit that's coming up. There is abroad a very, very strong feeling that the seeing of a doctor is something that rests in the past. That now you talk to him over the phone if you're lucky. You don't talk to the same doctor all the time. You talk to a practice. So the question of a doctor having continuity with a patient, and what we're talking about here with planning for winter, we're trying to stop the things happening that get worse in winter that we know about now, as well as the falls and all the other things that go with it. I just put this in context because we had our local health, local community health meeting this morning, and this point was almost flogged to death. And it was felt very much across the board that we are building up a backlog of people with problems that haven't been properly seen, because, as I say, you can ring up the practice, you can eventually get to see a doctor, but it might be somebody who's just joined yesterday as a locum, whereas the people who've been dealing with you have been for years. So when are we going to get round to waving the big stick to doctors and saying, you really are going to have to talk to people, because diagnosis starts with when they walk through your surgery door, not when they pick up the phone, because you can't see them, you don't know what's happening, you can't see their faces. There's a lot more to it than perhaps a Zoom call or a Skype call or a telephone call. I could flog it to death, but you know, I think you've got the point, have you?
So I'm just going to give a brief response and then ask Gaynor if she wants to add. So I think you started by talking about telephone calls and then you moved on to video calls. I think one of the things that all partners are doing is evaluating both nationally and locally what sorts of patients can be well managed through video consultations and which patients can't. I think the other thing that we are doing is continuing and stepping up our annual review process for patients. And I'm sure that Gaynor will add to that. So we are very conscious that people who need an annual review and a consultation around their long-term conditions in particular, sorry, I have a lockdown dog who doesn't behave. And so I think the proactive care piece is still an absolutely critical part, and we clearly won't be giving flu jabs over the telephone, so there will be face-to-face opportunities. Gaynor, do you want to add to that? I'm sure this is an ongoing conversation that you would have had already with Councillor Latty.
Yeah, thank you, and yeah, thanks Councillor Latty for highlighting these issues. I think the first thing I'd like to say, given the media coverage over the last sort of 24 hours or so, is to give absolute assurance to colleagues and members that primary care is open. Primary care is open for business in Leeds. All of our 94 practices are open and have been open and have been seeing patients and are continuing to see patients. That said, I think that the way that patients are being seen is, as you would expect, has had to be varied because of some of the risks in terms of managing pandemics. So because we're in a command and control situation in relation to the pandemic, GP practices have been asked to adhere to a standard operating procedure as part of the delivery of their contract. That standard operating procedure requires 100% telephone triage. So before patients are seen, it's a requirement that there is that level of telephone triage. And then from there, the kind of next bit would be consultation via video. And then if it's not been possible to resolve the issue via phone or video, and if clinically appropriate, the patient would be seen face to face. 100% of our 94 practices are offering telephone triage. 100% of our practices are offering video consultations, and 100% of our practices are offering face-to-face consultations in the way that I've just described. And if I could maybe give some figures just to give some context. Now, we know that demand went down in terms of there were patients who weren't, as we know, accessing primary care services proactively at the height of the pandemic. In July of last year, so in July 19, we offered for the month of July last year 350,000 face-to-face appointments. In the month of July this year, we've offered just over 190,000 face-to-face appointments, and so that's in a month. Alongside that was a significant number, over 165,000 telephone appointments, video appointments, and appointments through other means. So as a total set of appointments in July of 2019, there was a total of 417 appointments through those various means offered to patients in Leeds. And in July of this year, we were at 370,000. So clearly a difference, but again, significant activity, 370,000 appointments in the month of July, at which time we knew that demand was still reduced because of people who were shielding. Again, I think as Helen said, our focus now in terms of as we moved from the height of the first wave of the pandemic into more of a stabilisation and reset, not only were practices asked to continue to be working in the way that I've just described, but practices were also directed nationally to start looking proactively at those patients who are vulnerable. And there's work going on both nationally and locally in terms of risk stratification. So how do practices proactively identify those patients that might be clinically vulnerable in some way? And how do they make sure that those are the patients that are being prioritised in terms of those reviews, those long-term condition reviews, those personalised care and support plans? Additionally, we've got a new workforce into our primary care networks, significantly from a pharmacy perspective. And again, there's a requirement to start nationally ramping up the number of structured medication reviews that are being offered by that pharmacy workforce. So I think hopefully there's some evidence and assurance there that our practices are open and are working and are seeing patients. Absolutely get that there's still some experiences for some people where that doesn't feel that that's real, or where some of that digital, more remote way of working feels more exclusive than inclusive. And there is work going on to understand, as Helen said before, how we make sure that we don't inadvertently disadvantage communities by working in this way. And like I say, a real genuine desire to respond to to getting ready for what increasing numbers, to get more proactive with vulnerable patients, but alongside that, balancing the risk of having to protect the workforce in general practice as well. Hopefully, sort of colleagues and members will appreciate that for many of our 94 practices, who are all independent businesses, their workforce can be quite small. So if any of that workforce, needs to isolate because of potential contacts with people, it can be quite significant. So we've had one experience of that, where there's been one practice in Leeds who've had a couple of their workforce who've tested positive, and then obviously the knock-on consequences. So we have been able to engage neighbouring practices within the PCN in terms of some buddying and some mutual aid arrangements. But I think for some smaller practices, the experience for some patients may be that they're facing a door that's locked with an entry system. And again, this is just to kind of protect the workforce in some of those practices, where being able to open the door freely to anybody walking in has been assessed as being of risk. I'll pause there because I'm sure colleagues have got other questions, and I'm happy to answer those.
Thank you. Do you need to come back, Councillor Latty?
I would just like to thank again for that extensive, comprehensive answer. But just to say that I do take an awful lot of her points, but I still remain convinced that a lot of the people I'm talking about are the vulnerable people, are the people who are not receptive to telephone and video appointments. They're also the sort of people who all their lives have been used to having a doctor. And I make this point again, that we no longer have doctors, we have practices. We don't know who we're dealing with. I do think I'm probably banging against a door that's not that wide open. So I'll say thank you very much and leave it at that.
Thanks, Councillor. Thanks, Councillor Latty. I think you're right. I think for lots of people, that experience of the model of general practice as was is never going to be the same again, and we need to understand how when we reset, how we take account of all of that. And like I said, don't cause inequalities or things that are adversely affecting patients. But I think as well as the pandemic, we're also sadly facing challenges in terms of our workforce in primary care. So, having doctors that come in to be GPs that then spend their kind of life's work being that family doctor and running a family practice are fewer and far between, sadly. So different ways of organising practices, which might mean that practices merge in order to have a shared workforce, or where we're having to, again, as driven nationally because of the situation right across the country, introduce a whole variety of new roles into general practice. It's people getting used to that way of working, and like I said, that model, sadly for some and welcome for others, will be set to continue.
Thank you. It is, because a couple of times I've had a cause to ring the GP over the last 6 months. Telephone appointments have really worked for me, but it is to be cognizant that that's not going to work for the whole population. Can I bring in Councillor Trustwell, please?
Yes, thanks, Chair. I think it was Napoleon who once said that no battle plan ever survives the first engagement with the enemy. And to some extent, I think that's true of all planning, including NHS contingency planning and resilience planning. Obviously, and I'm going to play my usual role of being Victoria Eaton's warm-up act, probably on part of this. we obviously have rehearsed before about whether lockdown was too late and the suspension of local testing and how many lives may have been lost in Leeds and the rest of the country. But when we emerged from lockdown, the principal foundation on which that was based was the promise of a world-beating testing system. And clearly that idea has been knocked into a cocked hat. And at the moment, we've obviously got a massive increase in the infection rate in Leeds. It's gone up from just under 5 to over 70 in a matter of relatively few weeks. We've got today the NHS providers saying that the testing system is going to seriously hobble the NHS capacity to treat patients because tests are not available and they're not being turned around quickly enough. We've got a situation where some of my constituents are contacting us as local councillors and saying, I can't get a test for my family or my child anywhere at all. We've got some who are being signposted outside of Leeds. We know that the so-called world leading system is really not contacting any more than about 3/4 of the people in Leeds who test positive, as I understand it. And of those, only about 56% of their close contacts have been contacted. So I'm just wondering if Victoria can give us an update on the testing system and what assistance we are receiving as a city from the government now we've gone on to the sort of second level of their particular interest. Just a few other then quick questions. Helen has reassured us on PPE, so hopefully that is going to be a robust situation, unlike what we faced previously. It would be useful to know what the latest position is regarding hospitalisation. Are the infection rates beginning to show up in terms of hospitalisation? And finally, Chair, thank you. I just want to come on to care homes. At our last meeting, Kath Roth indicated that something like 20% of our care homes were looking to be in rather dicey financial circumstances as a result of COVID. What's the latest situation? And moving on from that, what support is being given to our care homes in terms of PPE, in terms of testing, in terms of support, so that we don't replicate, let's say, the carnage that occurred during the first spike of this dreadful disease?
Right, thank you very much. So who wants to go first with those questions?
Shall I come in on the care homes one, Councillor Trustwell?
Thank you, Kath.
So we've got, there's about 10 care homes at the moment who are of concern, but nobody is coming to us and saying they need to close their doors within weeks. They're just finding it hard, and we're having an open conversation as best we can because they don't always tell us. So we've got about 10 that we have got some concerns about. Some care homes have coped with the reduction in numbers is by shrinking the number of staff that they have, furloughing people or just laying people off and closing wings of their care homes. So they've sort of shrunk to meet the size of residents they currently have. In terms of PPE supply, the government has announced that it will supply PPE free to care providers. You have to register via a portal and then you can get that sent. They will provide that quantum of PPE above what you would normally have. And we still have the safety net mechanism of the local authority supplying any care provider if for whatever reason they might run out urgently. So PPE feels pretty robust. We have given resources out to care homes through the Infection Control Fund. Not all of the money was claimed, so that allows us to then redistribute it with a slightly wider criteria, which I think the sum was, it was worth about £130 per bed to give further assistance. So we've done that. I'm waiting to see whether or not there will be a second round of Infection Control Fund going into the winter, because having the money to pay for staff to cover wages while they're self-isolating has been a really important feature of the control fund. But a sort of, while promises were sort of, noises were made nationally, nothing firm's come out. Testing is proving to be very challenging. It's quite a complicated system depending on the scenario. So if you suspect you have an outbreak, you go via what's called Pillar 1. If it's your routine testing, which is happening on a rolling programme of weekly for care staff and then 28 days for residents, that goes via Pillar 2. What I have seen is concern expressed by our Regional Public Health England colleagues saying they are issuing a significant quantum of tests, but only getting roughly half back. So where have the other half gone? And is it confusion about where, is it Pillar 1, is it Pillar 2, depending on, is it routine, is it an outbreak? Sometimes we use our very local facilities with LTHT where they offer us some tests if we need something done urgently, or is it, so we're not quite sure where they're being sent, but they're not coming back. And some care homes are reporting it's taking 7 days plus to get the result of the test, which makes managing staff really difficult. But potentially people are having to self-isolate when they don't need to. That affects all the ability to roster. What we don't want is an increased risk of maybe having to use agency staff if you've got people unnecessarily self-isolating. So I think some of what you've seen nationally is impacting on our care homes as well. So it's not great, and it could definitely do with improving. But, you know, people are managing, we're in a different place to where we were in March. And what we are seeing is a pattern of infection where I'd say it's about 70% it's staff that are being picked up as C positive through the routine testing. Primarily they're asymptomatic, much smaller number of care home residents testing positive. And what we need to remind ourselves is this time we have much higher PPE protocol in place than was in place in March. In March, it was you only need to wear a face mask and face shield if somebody is symptomatic. Now we just wear it all the time. So I'm hoping that the risk of transferring of infection to residents is reduced because of all the measures we've taken between now and then. But we'll just have to see how it goes. We have, I think it's 19 today out of 151 homes where we have either staff or a resident testing positive. But we don't have anything where it's, I think it's above 3 people affected. Victoria's probably got it, she lives and breathes this, she's probably got it all at her fingertips and can recite it in her sleep. But I think the last time I looked at it, there was nothing like, you know, it's 8 people and it's a whole wing of a care home. We're not seeing that yet, and hopefully won't. So I'll leave it there.
Thank you very much, Kath. Victoria, did you want to come in?
Yes, thanks, Councillor Hayden. So just on the broader testing issue, Councillor Trustwell, that I wouldn't disagree with anything you've just said. I mean, I guess we could have a longer conversation about this, but I guess the current position we're in, and most of the things that are hitting the media today are around the what's called the Pillar 2 testing, the national testing programme that's run by Department of Health and Social Care, which is there clearly is a lack of capacity. All of our testing sites, we had a report this morning, all of our local testing sites are at 100% capacity and clearly full to people who are trying to get through. And we understand this is down to national lab capacity issues, which will still take several weeks to sort out. So clearly the impact of having to deal with the response to that locally is huge. You know, I'm sure many people on this call have got inboxes full of people struggling to get a test, and I think what we're doing locally is trying to help support local people to navigate the system and get a test in any which way they can. What we don't do is clearly run that national system. So we can't, you know, we can only try and help people to navigate it. The issues that Kath's just described run alongside that. So in terms of the Pillar 1 testing, which is run nationally too, but it's run by Public Health England, there are still issues of tests not coming back, tests taking too long. So again, what we've done, and working really closely with our hospital colleagues, is we have been able to free up more lab capacity in LTHT to help speed up that process. So in both cases of the testing for the public and the testing within health and care, we've responded locally to make it as good as it can for the city, but clearly there's still those national challenges. When we had the visit last week from the National Cabinet Office, when we were put on the watch list of an area of concern, and there is a conversation about enhanced support and what that looks like and what support we would need as a city. You asked it in your question. We were really clear that the support we were asking for is to have better access to testing for local people and more control over that locally. And we also wanted to have more of a local contact tracing service, because we know that if we do it locally, we get better results. And we wanted to unblock the system on both of those issues as quick as we possibly can. In the meantime, we've clearly had this national issue completely kind of hit the country. So all of our energy to increase local testing for local people is now having to deal with ensuring that even key workers can get a test. So everybody's working flat out to try and resolve that. But we are raising with the national team, and we've done it again today, that we've got to have more local influence over both testing and tracing, because this is an example of when that doesn't happen, what the situation ends up as. So that's where we are at the moment. We've got our local pop-up testing van, which as a council we've set up to run alongside the national testing service. So we're using that resource as flexibly as we can to try to get people tested if they really can't get a test in the national system. But we're having to prioritise key workers and their families at the moment, and we want to increase that resource so we get at least more local safety nets when people can't access the local system, the national system. I will just finish and say having said all of that, our testing rate is still relatively high in Leeds, because we get the testing rate for the city every day. At the same time, we get our infection rate and the positivity rate. So before this issue with the national system, our testing rate was the highest in the whole of Yorkshire and Humber. It's still relatively high, it's still in the top 5. So despite all of the issues, we still are testing more than 1,000 local people a day. So we'll continue to do everything we can despite the issues. Can I just add one more point that, and hospital colleagues may want to comment on the numbers in LTHT, but in relation to your point, Councillor Trustwell, around the infection rate and how it's spreading. We're keeping a really close eye on the age, the trends across different age groups, and people will be aware that this latest wave was predominantly caused by a surge in cases in young adults. So in Leeds, the age group with the highest number of infections is still young adults. but in Leeds it's very closely followed by adults in the 35 to 64 age group. So it's not as stark as some other areas where it's absolutely about young adults and not about other ages. We are over the last week starting to see more spread into other age groups, and we now are seeing increases across all age groups in the city. So there's clear evidence that we have a problem right across the population. I'll leave it there. Thanks.
Thank you.
Thank you.
Councillor Hayden, is it okay if I come in and just describe some of the hospital points?
Absolutely, it's lovely to see you. Thank you.
Thank you, nice to see you as well. So I'll pick up on the 3 points, Councillor Trustwell. So the first one regarding PPE, we have at this moment in time sufficient stocks. We've got a really good tracker system in place, and we've got quite a large area where we've got a significant amount of our PPE. I won't tell you where that is given we're live on YouTube, but we have got a good stock of PPE. In terms of testing, we've been able to test our patients, those patients that are being admitted into the bed base, either non-electively, i.e. those patients that come into A&E and then subsequently need admission, or those patients that are coming for an elective procedure whereby they need an admission. We've been able to test all of those patients, and we've continued to do that since the COVID pandemic started. In addition to that, we've been testing staff, so any staff members that have had to self-isolate because of symptoms, we've managed to test those. And as at earlier this week, our total figures in terms of number of tests that we've undertaken through our internal labs is in excess of 100,000 tests, which is broken down by 64,500 patients, 6,800 care home patients, and nearly 6,000 staff or their household members, because clearly what we're trying to do is to try and get those staff members back into work as quickly as we possibly can. So that's in terms of the testing. In terms of the hospital infection rates, as I say, we've been testing all of our patients as they've been being admitted into hospital. At its peak, we had in the region of 240 patients who were in our bed base with confirmed COVID. And more recently, we've had that drop right down to single-digit figures, 4s and 5s. We have seen an increase predominantly this week. We're at around the 20 mark at the moment. So again, not anywhere near the volumes we had at the peak, but clearly an increasing volume, which we're responding to. And that's the reason why we've continued to test patients as they're being admitted, because what we do then at that point is we segregate patients off into the appropriate areas, i.e. those patients being cared for in areas whereby we know that the patients tested negative, or those patients where they've tested positive as well. So that's the position in terms of hospital infection rate as it stands.
Thank you. Is that covered everything, Councillor Trustwell?
Yeah, absolutely. Can I thank Kath, Victoria and Saj for those comprehensive answers to those questions? Thank you.
Just what I was thinking as well, really comprehensive. Thank you so much. Can we move to Dr. Beale, please?
Thank you, Chair. Couple of areas I'd like to explore. The first is picking up the third part of the title of this board, the active lifestyles, which we don't spend a lot of time on actually, but I think is a very important part of our remit, and particularly bearing in mind the left shift, the upstream approach that we need to be adopting to keep people from, as far as possible, needing to go to their GP or needing to go to the hospital. So my first question is about how do we help people keep physically active, adopting an active lifestyle over for the winter period. I think it's going to be very important to promote people caring for their health by adopting healthy lifestyles, and therefore keep out of needing to go to health services and other services. And my second area goes back to Councillor Trustwell's point about care homes, in terms of you'll remember the Health Watch Leeds report on the residents of care homes and their families, published earlier this year. Question to Shona or to Kath is, what are we doing
I think we might have frozen. John, can you hear us? Okay, if we, yeah, are you back?
The families were not always particularly.
I'm sorry to interrupt. We're really struggling to hear you. It's really slowing down. Can I ask for an answer to the first question, and then if you, and then we can maybe come back to
I'll come back on the second. Lovely,
thank you. So who's going to answer the Dr. Beale's first question about keeping active? I know we don't actually spend, because especially during this year with the pandemic on and everything, in terms of active lifestyles, but I have been having fortnightly one-to-ones with Councillor Rafiq and Mark Almond about the leisure centres and active lifestyles and active Leeds, and so I can maybe arrange for them to produce for Mark to produce a report for the next scrutiny board on what has been happening. But there's been an awful lot going on, and an awful lot went online, but I appreciate that's not always the best for. But I don't know whether, Kath, you wanted to talk about something about what the, Victoria, would you like to come in and how we're keeping people active? Thank you.
Thanks. So yeah, I think it would be great for the report you've just suggested, but just briefly, I think two of the key services that we've been really keen to keep going through the pandemic, and clearly continuing through the winter months, are the one new Leeds service, which is the overall healthy lifestyle service in Leeds, but also Active Leeds, which is run with our colleagues in leisure services. And we're really pleased, and I'm looking partly again here, we're really pleased that from the 21st of September, so I think that's next week, we're setting up a new referral pathway from all Leeds general practices to be able to directly refer to Active Leeds for people to have opportunities for a whole range of activities, including walking, cycling, etc. Which hopefully, if they all prove to be COVID safe, we can keep that going. As much outdoor activity as possible, I'm sure. So I think that's just something practical that we've done despite and because of the pandemic, that's working really closely with primary care. But there will be a much more comprehensive report that colleagues can bring from Active Leeds.
I believe that I've got a meeting on the 15th of October to the consultation document and the report that follows that Active Lead will be bringing to me. So we'll look to bring it to a future meeting. Dr. Beale, are you able to?
Hopefully I can. I've turned off
lovely.
the video in the hope that might stabilize the connection.
Excellent.
So I was really asking, and I was saying that Kath has told us that when some families did eventually get to see the residents in the care homes, they didn't always act responsibly and went marching in and threw their arms around their family members. Clearly, that is against all the rules, but it's very important that the families and the carers, the family carers of people in residential care do see their loved ones, not only for the health and well-being board of the person in residential care, but also the rest of the family as well. And I saw a couple of photographs earlier today of a lady who just before lockdown was looking quite generally healthy. She may well have been poorly, but she looked well, playing with her granddaughter. During lockdown, went into a care home. A second photograph taken very recently, when one can only describe it as a very elderly and poor looking old woman. So, having not been able to see her family over that period of time has had a disastrous effect. Now, that might have happened anyhow in that particular instance, but we do need to make sure that the residents can see their families. And secondly, are we able to be ensured that activities, at least some activities, some maybe can't, but activities within care homes will continue for the residents of those care homes? I know singing in churches is not allowed at the moment, but I guess older ladies and gentlemen don't actually produce as much aerosol as cathedral choirs. So maybe they could do a bit of singing in the care home. I'm sure they can do a number of other things. So are we trying to make sure that people in care homes do have whatever activities they can to keep them occupied and in a state of well-being?
Thank you. Kath, did you want to come in there?
Yeah, I mean, I think supporting family visits is a really critical issue. We've got to get the balance right between risk and having a meaningful and fulfilling life. We issued our own advice before the government advice came out, and we've seen from the care sector some very creative ways in which visiting can be done, hopefully in the most safe way. Obviously, with the weather drawing in and it's getting colder and darker, the ability to do some of the garden visits is going to be fettered. So having a look at different ways of doing it. Certainly what I would like to see is that family members get added to the routine testing that is available to staff, so they can be seen as an essential part of somebody's life as much as the paid staff. I think we are some way off that being in any way remotely happening until we can't even get sort of key workers tested routinely in a safe way. It's a little way off getting family members routinely tested, but that's what we would like to see. Obviously, because of the status of our infection rates, Victoria has to issue advice out to the care homes, which we do through our weekly bulletin, and they do take individual decisions based on their own perception of risk. Obviously, we've got about 16 homes, I think, that are closed because of current infections, and that's understandable. So it's just trying to sort of balance the risk with the absolutely essential human contact that care home residents need from their loved ones. And I don't think there's any easy or right answer around this. We are hearing some homes having some real challenges around their insurance cover as well. Certainly insurance premiums are going up, and I think their insurers will look very closely at what their visiting protocols are. And I hear, not in Leeds, but nationally, I've heard stories of quite hard positions taken around restricting access connected to insurance cover. In terms of activities, again, I think we've seen some extraordinary creativity from care staff to continue to try and provide stimulation and meaningful activities for residents. Sometimes it depends on the staff complement that's available, because obviously if people are hard pressed in terms of staff cover, I think one of the first things that gets conceded is the activities bit of it. But we are trying to encourage and support care homes to be as creative as possible, because, you know, if they're not going to get the mental stimulation from seeing their family members, they need to do it from the community of residents and staff that's within the care home. But, you know, I think practice is variable, it's safe to say. We're keeping an eye on it. We're trying to encourage and support as best we can.
Thank you. It's,
Thank you, Kath.
yeah, it's a really interesting area of ongoing concern, and I'm sure you're working really hard with it. Thank you, Dr. Beale. I'm going to go to Councillor Knight, then Harrington, Councillor Elliott, and then Councillor Reagan. So Councillor Knight, please.
Hi there, thank you. So my question is around a reference in the PowerPoint report to development plans in relation to children's primary care, the capacity for children's primary care specifically. And I'm wondering whether, when planning for that, account will be being taken of recent studies which are suggesting strongly that COVID symptoms in young children are not necessarily the three that we're aware of, that we've always been aware of, but are also often presenting as gastrointestinal symptoms, and what approach will be taken by GPs, for example, towards children who present with gastrointestinal symptoms, possibly of COVID. Obviously, that could be other things, but will they be investigating whether those symptoms are COVID related? And I appreciate that that's going to add to an already struggling system of testing for COVID, but to what extent are we taking those reports seriously? Thank you.
If I just respond briefly, Councillor Hayden.
Absolutely, Helen, thank you.
The piece of work is the piece of work that we're doing jointly between general practice and the hospital to see whether we can provide some enhanced clinics for children after school, when we know people come home after school, don't feel very well, and to provide some additional capacity system through the 111 service, so that people can, if they can't get a primary care appointment, so that they can turn up in A&E for and travel with whatever it is that's that they have, to provide some additional capacity. So again, has been involved in that piece of work. I believe that we're just about to be able to start that. I can't respond in detail around the clinical pathways, Councillor Knight, but what I can do is ask our lead commissioner for children's services just to provide some confirmation. I suppose my general response would be that I expect general practice to be up to date in national guidance around diagnostics, and I'm sure that they are, but I will seek some assurance around specifically whether we've updated any of our pathways work around children's presenting symptoms. I know there's been an ongoing conversation with 111 this week about who gets directed there. So I'm guessing that piece of work around what's a trigger for children's testing. I don't know if you want to add.
Gaynor, did you want to come in there?
Yeah, thank you. Thanks, Helen. Yeah, I think you're right in terms of just making sure that we've got everything, documented down in terms of the right pathways. It's very difficult for children, isn't it, given that their symptoms and their kind of condition can change very quickly. So GPs are always very heightened to how unwell children are presenting. And as Helen said, the work that we're doing with LTHT to look at if there are children that present at the emergency department, if those children don't need to be seen in the acute setting, how we can make sure there's really good connection back into primary care services so that those children are seen and seen appropriately and safely.
Thank you very much. Can I ask Councillor Harrington, please?
Thank you.
Yes, thank you very much. It's a really quick question, hopefully, for Kath. It's with regard to the Pillar 2 testing, Kath, and there's one particular home in the Wetherby ward that I'm aware of where they've been told, the workers have been told that they're not going to bother doing any testing because they can't get the results back. So when you said that there seemed to be an awful lot of tests, somebody said there were an awful lot of tests going out, but they weren't all necessarily coming back, that it may be that some care homes are actually doing the same thing. And so that what they've been saying to staff is, well, when we can get some indication of when we're likely to get some test results back, then we'll start testing staff again. But they haven't been tested for at least a month. So I'm quite concerned about that. It may be that we have to have a private conversation about it, but I'm just wondering what kind of support is being given to care homes that are parts of kind of national organisations, although they're actually being commissioned to look after some of our residents. Thank you.
Certainly have heard of homes getting to the point where they're saying, well, what's the point? If it's taking 7 days plus, it's not operationally useful to them. It would be helpful to know which home you are referring to, although I could probably work it out by a process of deduction. But if you could drop me a line, that would be helpful, because we'll have a conversation with them. We certainly know some of the big homes just physically cannot swab all their staff in one day either. It's just not possible. So they have to do a rolling programme anyway. But we would still encourage them to take up routine testing. I think the fact that a number of people have been picked up who have been asymptomatic and tested positive is reason for why you would have testing, although, you know, we would always say just observe the best infection protection control measures in your practice, and just having knowledge around testing outcomes is sort of secondary almost to safe infection control practice. But if you let me know which home it is, we'll have a chat with them about it.
Yeah, I will do. Thank you, Kath.
Thank you very much. Councillor Elliott, please.
Thank you, Chair. I'm really wanting to say that the testing will be difficult. We shall find that people can't get the test they're wanting done if a large amount of our citizens don't stop meeting in great big groups, as they've been asked not to do. I think we need to keep that message pounding out that they have to be careful, and they're really not taking any notice. And until these people start being responsible and behaving as they should behave, we shall be in a very poor position. I do want to make another comment, please, and that is, I think that we councillors should be thanking Marianna Pexton and Councillor Judith Blake for all the information that we have been given on a daily basis about the coronavirus. Thank you.
Thank you. I don't know whether anybody wants to respond to that. Thank you. Victoria, would you?
Yeah, can I just comment? I think I fully support the comments from Councillor Elliott around what we can do to stop the spread. Testing is clearly only one issue, and the only way we're going to reduce our rates is to reduce contacts where the virus is transmitted. So unless we really deal with the that issue around how we can reduce contacts that are the easiest ones to reduce. We know from our the intelligence we do get from the contact tracing system, and most of it is the local system, that we still have the majority of transmission through social gatherings, whether that's social gatherings in private households or social gatherings in the hospitality sector. So this is why there is a focus on trying to limit the spread within social gatherings. It's much less likely to be in workplaces and other more controlled environments. So yeah, I just would support your comments to say we need to look at reducing our contacts in the best way that we can, whilst we keep people with us and we keep society going and the economy going as much as we can. And it's that difficult balance we need to continue to strike. these will be the conversations we'll be continuing to have with our national colleagues as the week continues.
Sure you will. Thank you. I'm sure you will. Thank you.
Thank you. Can I bring in Councillor Reagan, please?
Thank you, Chair. I don't know whether mine's a comment or a question, or it might be both, but it's linked back to the winter planning and the issue that we've got with COVID and our vulnerable elderly. We've seen all the neighbourhood networks in the city stepping up to the plate and doing above and beyond to keep in touch with these vulnerable elderly people. And I think there needs more support for the neighbourhood networks in this interim period, because they can't get back to doing what they do in a sense of doing activities to keep the elderly more active and to stop the isolation. So I'd want to look at how we can promote that more within this context of where we are, because it's a real issue for our neighbourhood networks, because they're having to get extended funding from other charitable organisations, and they can't get that funding because they can't do the activities. So you know, there's a real dilemma there.
So can I just respond to that, Councillor Hayden?
Absolutely.
Just to be absolutely clear, the council has maintained its funding to neighbourhood networks. We've not cut it or reduced it. We've worked with them to work through how they may adapt or change their funding model. Possibly what the other councillor is referring to is where they had like a trading activity as part of their, you know, they ran a charity shop as part of their sort of business profile, or whether or not there's external funders who've required them to, you know, definitely produce activities, statistics around people attending, I don't know, lunch clubs or something. But we have tried to support our neighbourhood networks to negotiate with those other external funders. But certainly the ones where it had a traded activity, you know, I do recognise that that has been difficult. And the council is not in a financial position to step in and make good any income they lose through that.
Thank you. I know that our neighbourhood network received some COVID funding, some extra funding from the COVID pot, but I don't know whether that's the same for all neighbourhood networks.
Can I just come back on that, Helen?
Yeah, sure.
I mean,
yeah.
Yes, they have, but you know, and it's great, isn't it, that we're supporting them with the main core grant, but that only provides basic funding to keep the organisation afloat. A lot of the activities that they do, the luncheon clubs and all the rest of it, they can't take place because of the COVID restrictions of less than 6 people meeting in community spaces. So that adds to the isolation, and it will add to more elderly people going into hospital care over the winter period.
Yes, and it's very difficult to address that. And I've had people in my ward asking when the clubs and the activities are going to restart, and it's heartbreaking to say, you know, until the restrictions are lifted, they won't be. And again, when it's coming into winter, because our neighbourhood network volunteers and workers have been standing on doorsteps talking to people or through windows, but that's not going to be possible if the weather's when the weather comes in and it's really bad. So it is going to be really difficult, and people are suffering as a result. So if I can ask Helen to just give us some Helen Lewis, sorry, to give us some basically many thanks for answering this question so comprehensively, but if you could ask talk to us about the next steps in our resilience planning. I won't use the word winter. Just to say what's going to happen going forward, please.
Thank you, Councillor Hayden. I'm conscious that you've also had adults and health business continuity plan, so I wasn't sure whether you were taking it as a separate item. So
well, it's not going to be
all
a
of
separate
Shona,
item,
so
but,
taken all of Shona and Kath's time.
That's fine.
So the next steps are, we've got the Local Health Resilience Forum is doing a kind of stress test tomorrow. So I think there's a constant iteration. I think I would just go back to what I said before, which is we're now testing this live, and you know, as of today, we're already seeing significant pressures in the system. And Saj's just talked to you about, you know, as of today, we've needed to create an additional COVID ward and therefore moving patients around the system, and our occupancy levels are already increasing. So I think it's safe to say we are testing our principles and our flexibilities already. The next formal step is that we are having a system review meeting on the 30th, and then we'll go back to Health and Care Gold on the 5th of October to describe the key actions, the key milestones. Probably worth also mentioning, just while councillors are on the call, that we're also responding to new hospital guidance, so hospital discharge guidance, which is slightly more thought through than what we were doing in March, around making sure that only people who absolutely clinically essentially need to be in hospital stay in hospital, and that creating capacity, ideally in people's own homes, or if not in community bed settings, for people to have their further assessments. We've had a really detailed planning meeting around that this morning as well. So as a health system, we're really focusing on how we create capacity for people to have their ongoing needs assessed outside of the hospital setting, to free up the hospital for those people who absolutely need hospital care. So that's not without its challenges. We want to reflect on mental health capacity as well. So colleague from Mental Health Trust on the call, but we're working as a health economy to see if we can create some additional capacity in mental health services, recognising that there's two kinds of COVID surge. There's people with COVID and there's people affected by COVID, and we're seeing increased need for people with mental health conditions. There's another piece of planning, particularly around the ICS footprint, integrated care system footprint, but also around work with third sector to maximise the support that we can give to people with mental health needs to address that surge in mental health demand that I know Victoria familiar with as well. So I think we have constant system calls, and each part of the system is much better connected through a Zoom, through a Teams call now, weekly or fortnightly, around those things that we can do as a system. So I think we're ongoing testing, but I think what we're really doing is moving into a live, ongoing response situation and just continuing to flex as best we can through partners. The step up is almost to reverse all the things we stepped down. So I guess our step up plan, Sam might want to comment, is taking down those things which are more discretionary, which are the things we stopped previously. I think what I started with, and I'll finish with, I guess, is our aspiration is to only step those things down if we absolutely don't have enough staff to keep those things going safely. Whereas before, what we did was we stopped everything because we didn't know what was going to happen. We still don't know what's going to happen, but we're clearer of the impacts of stepping some of those things down. So we are having system conversations daily, weekly, whatever we need to do to balance those risks on behalf of the population and the population's health needs. Whereas I think the first time things like, well, Saj could talk to us, you know, we closed all our theatres because we thought we'd need them for intensive care. We've got a more robust system. We won't need to do that again. So there are some things which will be better, and there will be things that will be equally challenging. So I think it's a live testing system. The formal steps are going back to Health and Care Gold on the 5th of October. But the plan is the plan that we've described to you, which is how do we work really flexibly and use the capacity we have to best effect, bearing in mind all the uncertainties. I think it's probably the best way to describe our plan, unless colleagues would like to add to that.
Thank you very much. Sam, would you like to add to that?
Only that I think everybody worked in good faith the first time round, and we did things that we felt were absolutely necessary, but it was a learning opportunity as well. And there were some services definitely that we done in community that we wouldn't do again in the same way. We may need to look at how we reduce some of those services, but we wouldn't stop them. But I think we're very well aware of those now.
Thank you very much. I'm just wondering if anybody else would like to comment. Yeah, Councillor Lay, would you like to come in?
Yes, I am here.
Yeah.
that was really interesting. 5 minutes there, really. So we've reintroduced a COVID positive ward. Obviously, back in March, we didn't know as much as we did, and like you say, we shut down lots of services and we redeployed staff. We had surgeons who thought that they might be intubating patients. There was all manner of absolute chaos, and everybody stepped up and helped across specialities. We're not going to do that again, by the sounds of things. Certainly not in the same way. But the risk is still there for our colleagues. Medical isolation is still there for our colleagues. We took all of our third-year students and fourth and fifth year medical students, and we turned them into aspirant nurses or whatever, and we asked them to work clinically. If the proverbial does hit the fan, where are all those additional staff going to come from? Because obviously as a frontline worker, I'm conscious of the fact that for the first time in 30 years, I don't just have to worry about the patient's safety, I now have to worry about my colleagues' safety as well. And we have to remember that more health and social care workers are purported to have died from COVID than our soldiers during the Iraq War. And there is still a genuine risk to our work colleagues. So I'm just wondering, when we talk about, well, we're going to continue to keep services going, whether that will be at the cost of.
So yeah, so Councillor, thank you. Sorry, I probably should have caveated that more clearly. I'm going to ask Saj to comment because he's got the detail of the step-up plans within the hospital around how that resilience will work. What I should have said was we will keep services going until the point where staffing does not allow, and we have to make those choices. So I didn't say that clearly enough. So the conversation that Sam and I have just had is we will clearly have to redeploy staff so that the staff on the front line are well enough supported that we can maintain the safety of those staff. I think the other thing that's different is PPE. I think the other thing that is different is testing. But as Gaynor referred to before, we are absolutely mindful that the health of our staff, and I think it's true in the Mental Health Trust too, that the health of our staff, particularly of our BME staff, has been absolutely foremost. And one of the conversations about, face-to-face care is there are choices between the preferences of our patients and the safety of our staff. And I think that is a theme all the way through the work. I'm going to ask Saj, if that's okay, Councillor, to respond to the kind of the medical workforce issue and the nursing workforce issue as well, and particularly around students, because I'm not sure of the answer to that.
So I can come in on some of those areas. So I think the big difference. So last time we were at the point we stepped the majority of things down, the routine things. We were in a level 4 critical incident that was being managed and highlighted to us in terms of the actions we needed to take nationally. Because we didn't know how the spread was working and the detail behind the virus, as you quite rightly highlighted, the majority of our clinical workforce was geared up to deal with COVID presentations, so surgeons, helping anaesthetists, etc. What we've now got is a position whereby we are clinically reviewing all of our patients and prioritising those patients that were the elective patients who have been waiting for their procedures. So our clinicians are undergoing clinical validation of the waiting list and prioritising those that we classify as priority 1 and priority 2. So that's our rhythm of managing patients based on clinical need. Once we've managed through the P1 and the P2, so the priority 1 and the priority 2 patients, we will start to work through the chronological order, so the long waiters. Of course, we can do that at the moment with the number of COVID positive patients that we have in our bed base and the precautions that we have in place. So as I was highlighting, because we continually test our patients, so at day 7 being an inpatient, we're testing patients coming through elective routes, patients coming through non-elective routes with testing. So we know we can keep patients and our staff safe based on those testing regimes that we've got in play. Clearly, there will come a tipping point if we get back up to the levels that we were in COVID phase 1 or the original spike. Then we will need to designate additional wards to the care for those COVID positive patients. But what we've got is we've got a ward by ward plan of which ward we move to next and how we staff that ward. So what we'll start to see is that we would look to start pulling those clinical and nursing teams from the existing work. So for example, those that are doing elective work at the moment to focusing on the non-elective work that comes through. So that's the way we would look to do it, as opposed to last time, where clearly we needed to try and create as much capacity in one go as we possibly could, given we didn't know how many patients we would get coming through the doors with COVID. So I think that's as I can put it simply in terms of how we intend on going back up. Clearly, if we get back up to the volumes of 240, 250, we will start impacting on our ability to maintain the elective work programme. And as Helen says, these patients are the very patients that would be waiting a long period of time or have been cancelled previously. So it's not our first line option, really.
No, I guess.
Thank you very much.
Well, can I just come back, Helen?
Yeah, sure, yeah.
Yeah. I guess the worry is, isn't it? Normally we sit here and we talk about our winter pressures and we talk about bulge wards or you know, introducing additional winter wards that we will staff however we staff them usually, yeah. But we're already talking about losing the resilience report talks about 100 and 130 beds already having been lost because of social distancing. I assume that's things like turning 6-bedded bays into 4-bedded bays, but that's still quite a lot of beds that we're going to go into a winter, which winter is always difficult, not because necessarily of demand, but of acuity and longer hospitalization. And we've got this other two elements hanging over us. One is we don't quite know what COVID will do in the winter, because if back in March we were saying protect the NHS, let's get through to the summer. Well, we can't say that now. Let's protect the NHS, let's get through to winter. You know, that doesn't work the same way. But at the same time, we've got all these consequences of the impact of COVID. So on our cancer patients, on our heart patients, on our diabetic patients, etc., which will also increase excess deaths. So it's a really hard balancing act. And I have to say how proud I am of Leeds Teaching Hospital and the local Leeds health and social care community in how willing you are to recognise that there are these conflicting priorities, and there is unfortunately going to have to be some give somewhere, and we just don't know yet. So thank you from my point of view as a healthcare worker for considering staff, of course, but I do understand that we've also got to consider not just the COVID sufferers, but all those other patients who need the health service as well. So
Thank you.
Thank you.
Thank you, Sandy. I couldn't have put it better myself. And, you know, as Councillor Elliott said earlier about thanking Mariana Pexton, I did, in another meeting, I thanked that Mariana was on, I did pass on my thanks. It's been an incredible team effort. I am conscious of time and that we haven't discussed the business continuity plan, but a huge thank you to everyone in the partnership work, and I'm very proud to be a Leeds resident and very proud of Leeds and the way that the whole system is working together. And I am, and we're all pass on our thanks from everybody. On the subject of business continuity, is going to be a huge and resilience is going to be a huge issue for us, and we'll keep an eye on. Shona, would you like to comment on the report? But we are coming back to it in the next couple of weeks as well. But if you'd like to comment on it, and then we can, it'd be nice to hear from you. Thank you.
Okay, thanks.
Councillor Hayden, would it be okay if, for health partners to leave? I think people have got
Absolutely, absolutely, yes.
I'll
Sorry,
stay.
me thanking you always like
no,
huge.
that's fine. I'm happy to stay in spirit of partnership, but I'm conscious that
Oh, no, absolutely.
might be
Me thanking you was
really
like,
busy this afternoon. Would you mind?
You may all go.
I'm going to stay because I'm going to
much.
evidence partnership working, but I'm just conscious that some colleagues have come in on their day off. So
Thank you.
Thank you. Thanks, Sam.
I should have said that. Thank you, Helen. Right, yes, Shona, if you could yeah, talk to the continuity. Yeah.
Thank you, Councillor Hayden. There was a report received by Scrutiny chairs about business continuity planning across the council, and it was felt it would be useful for other scrutiny boards to receive a paper about the business continuity plans in their specific area. So that's partly why the paper's here. As I put in the paper, it's a statutory duty of all local authorities to have business continuity plans. And within adults and health, we do have a number of those plans. There's a Directorate Resilience Group which meets twice a year, and it receives updates on the business continuity plans and also performance manages them, so it makes sure that they're kept up to date. And at the beginning of this year, the March meeting, which happened just as we were hitting crisis with COVID-19, it was noted that we were agreeing on all of the business continuity plans that we had. That those have now slipped slightly. Appendix 1 shows that there's two that are due and that were due in June. One of those has been done already and the other one is almost complete. So we're almost back to totally green across the board on business continuity plans. I think one of the interesting things about business continuity plans is that they're very good when it comes to an emergency. So when we had the floods in 2015 and we had assisted living Leeds was physically engulfed with the floods then, business continuity plan was brilliant in supporting the managers and the staff in that service to understand exactly what they needed to do in response to that immediate crisis. That lasted for 5 or 6 days until they were able to get back into the building and start to restore and recover. With COVID, it was slightly different. We didn't really have a 5-day crisis and then it was over and we were able to get back. It just built and built. So in a way, we were reinventing or inventing new ground in terms of how we responded. So we had the initial business continuity plan to support our immediate response, and then we found ourselves in a what people started calling the new normal. So there was areas of the business that we were doing things that were nothing to do with the business continuity plan because they were a completely new terrain. So we will have learnt from this whenever we are revising the business continuity plans. We will have learnt from this whole incident really, but it's more than an incident, isn't it? It's the way we live our life now. So as I say, it was useful at the beginning. We will learn from what we did immediately after the immediate crisis of COVID-19 and build those into future business continuity plans. And we've moved beyond the original business continuity response into a business as usual situation. So I'll leave it there if there's any questions or any comments from anyone.
Thank you. Are there any questions for Shona on the continuity? I think it showed that it did work. You know, we've often looked at the continuity plans, haven't we, and over the years, and it was really needed and it really worked. So yes. So I don't think I've got any comments. So that's great. And obviously we will keep coming back to looking at this as we go forward. But thank you for being here this afternoon. It's been a lot to take in. I think all colleagues will agree, but the level of expertise and knowledge is just second to none. I'm just incredibly impressed, and you know, I don't know how you're all doing it, to be quite honest. It's really impressive, and huge thank you. Not just for this afternoon, but for everything you've done over the last 6 months and everything that you're going to have to do going forward. And we'll see you again soon, I'm very sure. Although you might not want to be here, but we will. Thank you so much. Right, Angela, if we go on to the work scrutiny? No, sorry, schedule, please.
Thank you, Chair. So yeah, this is the last agenda item. So this report asks the board to consider its work schedule for the remainder of this municipal year. So the latest version of the schedule you'll find in Appendix 1 of the report. With regard to the next meeting in particular, the board is going to be focusing its attention on how COVID-19 has impacted specifically on local mental health services. Also scheduled for October is an item on budget saving proposals. So initial proposals relating to the budget are expected to be considered by Executive Board at its meeting next week, with a view to consultation on those taking place during the autumn. As part of that consultation process, it was agreed with all scrutiny chairs that the proposals being taken would be formally considered by the scrutiny boards as related to their respective remits during their October meeting cycle. But prior to the scrutiny boards meeting on the 20th of October, there's also a remote working group meeting that's been planned for the 5th of October at 10 o'clock. And this is to provide the opportunity for board members to discuss the option appraisal process that is linked to the development of the budget saving proposals. So invitations have already been extended to all board members with regards to that meeting. Just to provide a further update surrounding Avery Leisure Centre. So during the board's last meeting, it was agreed that the chair and I would consider how best to still accommodate this outstanding piece of scrutiny work from last year in relation to the issues that were surrounding the renovation of Avery Leisure Centre. So linked to this, the chair would like to hold a remote working group meeting during late October for all board members to discuss the details of the renovation project, the issues encountered, but more importantly, any lessons arising from that. So, and following this, the working group's findings and conclusions will be reported back to the full scrutiny board as part of its November meeting. So once a date has been identified for this working group meeting, then I'll circulate invitations to all board members. So to conclude, Chair, members are asked to consider and agree or make any further suggested amendments to its work schedule at this stage. Thank you.
Thank you very much. Any comments on the work schedule? No? Thank you. It's going to be a lot going forward, and we've got a lot to tackle. So, but no, I thank you all for your work since we started back in May with working groups online, and for your excellent questions today and input, and the level of expertise on this board and knowledge of your communities is just second to none, and I really, really appreciate it. So shall I wish the date of the next meeting is, so is that one in November with the working groups, obviously previous to that, which have gone into diaries as well. So I look forward to seeing as many of you as possible. And Councillor Latte, have a lovely holiday. I hope it all goes to plan.
Councillor Hayden, just to say, I think Councillor Elliott's indicated to speak.
Oh, sorry.
Pitching.
Yes, exactly. Councillor Elliott, and then Councillor Lay, please. Councillor Elliott.
I just want to say, well done, Chair.
Oh,
I think
you.
you've done really well in such very difficult circumstances. Well done.
Oh, thank you. That is really, really kind. It's not the easiest chairing online. You have to be very, always aware all the time. The hands up, it really helps, but it's not the same as being in the room. So thank you very much. I really appreciate that. Councillor Lay.
Yeah, Helen, I've got the 20th of October as the next meeting. Is that right?
Working group.
That's the working group. Is that the Airborough thing?
No, we haven't established a date for that yet.
Oh, right. I was going to say that I'm available that day. So.
All right. So
I didn't know that.
Is the next meeting the 20th?
Just to confirm, the next formal public meeting is the 20th of October.
Right. Yes.
Prior to that is the budget saving proposals working group on the 5th of October, and I'm yet to find a date for the Avery Leisure Centre working group.
Yeah. Okay. Sorry, my mistake.
Be that morning then.
I'm thinking ahead to November because we're doing the budget things in October, and yeah, sorry, I'm getting ahead of myself.
Yeah, that's all right. Thank you very much.
Sorry, Sandy. Thank you for clearing that up. Okay, thank you very much, and have a lovely evening. Enjoy the sunshine.
Bye. Thank you. Bye.
Enjoy this one. Thank